Again, thank you very much that for the generous and introduction and also it's great pleasure and honor for me to present this in front of all my teachers and senior colleagues and also my students. So today I would like to talk about this universal health care and achievable goal. Because I selected this topic, now it is very important that even 2000 all the countries leader met in New York, and they decided to consider 8 goals identified as a Millennium Development Goal to achieve by 2015. Then before that I have to go back a little bit further. In 1978 that Alma Ata declaration by WHO that health for all by 2000, but they couldn't achieve. Then again they met in 2000 and they developed the goals and the targets to achieve by 2015. Even last year this World Health Report produced by the WHO talking about this universal health care and they wanted a lot of research about this. So I thought to take this as an opportunity to share some of the information and for make a discussion point how we can achieve this universal health care, particularly in Sri Lanka and in the northern part of Sri Lanka. So these are the content areas that I am planning to cover: the universal health care, and also I would like to touch a little bit about the Sri Lankan health system and then Sri Lankan health problems. There are we know these unique problems already. Dr. Svejogan and Murali Velimunathan touched some of the issues related to that. Those are special for our region. Then we can go to this what we can achieve and what are we doing at the moment. So a little bit of theory part to covering this universal health cover and that. So the people obtain these health services they need without suffering financial hardship when paying for them. So then the health is very important, and also when they get ill and or if they want to get the health services, they should get the health services without any sort of financial constraint. So what are the factors could affect health coverage? When we look at those, first thing is it's very important to have a well-run health system. Then this affordability, actually the finance system. Again, then service provision and availability of technology, diagnosis and things. Then the fourth one is about the health human resource development. The fifth one, the critical role, that's a multi-sectoral, intersectoral coordination. So the health system defines include the all primary purpose to promote, restore or maintain health. So this must be integrated. So actually when we look at this health system, so people are the center point, but most our health system still that service providers are in the center and then people are somewhere outside. So this is the problem, particularly our health system we have. So strong, efficient, well-run health system should have then this priority for the diseases which are available and should be able to look at the priorities and the capacity to treat and also the helping the patients with rehabilitation. This was raised some of the previous discussion also about these rehabilitation facilities. So most of the time our health system failed to look at all these, particularly the early detection and also providing rehabilitation. We provide services after getting the ill and then providing this treatment for the ill people and then that also there are a lot of issues related to follow-up and also providing rehabilitation and even for this later this palliative care. So when we look at this health system, our health system is considered as one of the most efficient health system in this part of the world, because our indicators are very good compared to other countries in the region, except these indicators related to nutrition. So as I told, these outcomes are very good, and also that the next present I will compare that about this American health expenditure and Sri Lankan health expenditure. When we look at this health expenditure, this GDP wise, the Sri Lanka spent only 4.2% GDP, and out of that able to achieve all these good marvelous indicators, and also able to bring down maternal and child health morbidity and mortalities, and also reduce down the communicable diseases, and life expectancy have gone up, and then people are living around more than 70 years. But now these new challenges are coming up. That first thing is growing and shifting health needs of this country, and also this transformation of the economy. That country earlier it was a low income country, now lower middle income country, and then projecting to become as a upper middle income country in 10 years time. So this economic growth and changes in social demographic and epidemiological thing, that particularly non-communicable diseases are becoming more and more. This has been discussed in so many presentations and so many publications, and also this scarcity of resources. That again another challenge, and the main problem to know regular update of this system. The system is not functioning, or is not monitored and evaluated properly. Already I mentioned this main funding is from state, but even though main funding is state, over 40-50% of the funding is coming from patients out of pocket. Most of the investigations and some of the drugs are not available in the even tertiary specialty care centers, so patients are expected to go and buy outside, or ask them to go and do the investigations outside. So out of pocket expenditure is increasing over the time, and large private sector hospitals are growing up. Then in the private sector without proper monitoring and regulations, so there are a lot of allegations and irregularities are reported about these private sectors. And also when we look at the positive thing, then as I mentioned, the positive aspects are the increases education status of people's expectation, and greater demand of quality of health. So people are also expecting high quality of health. Then negative things what are happening: changing lifestyle, consuming more fast food and unhealthy diets, and consumption of more alcohol and tobacco, living in polluted environment and trauma due to occupational and other new exposures. And aging population, it is highlighted by Murali Valimunathan. Then the increasing non-communicable diseases. So this is a present situation. This diagram best explain about this present situation of our health system and financing. We have a problem with the coverage, and also we have the problem with escalating the cost, and also we have the problem of the increasing the vulnerability on vulnerable groups. So this dimension clearly explain that we have gaps everywhere. So these gaps need to be filled up. So already I mentioned. So when we even go to some of the areas, still areas are not covered by primary health care services. When we take this Nallur MOH as an area, we have this teaching. The Nallur area is expanding from Kondavil to up to Ariyala East, but we have only 2 primary health care centers, one in Kondavil and another one in Cockeville, but there is no primary care center in whole Ariyala. Then Ariyala, East Ariyala, Pumbuga people need to travel to either Jaffna OPD or go to the Kurunakar hospital. So then they get bus transport in the morning and the afternoon. So then when they go in the morning, then they have to come by afternoon. So this coverage is, still we have the coverage problem, particularly in the primary care. And most of the primary care institutions, again we have the problem at underutilized, and we don't have properly trained medical officers and paramedics. So still we need more and more trained and strengthened human resource and also equipments and other facilities. So again I told you this expenditure is going up, and then particularly we are getting more and more chronic disease patients. Diabetic patients are more prevalent in this country. Now then CKD is going up, then heart diseases and cataract. So then the cost for this treating the patients, and also the increasing elderly population, and also we have the disabled people to be provide all this rehabilitation and long-term care. And also in the health system we have the main problem with the patient safety and quality improvement. Our health system is like this. So flights are on time, so we don't have any backlog like waiting time or this for the patients. Anytime they can get, immediately they get the services. Most of the time compared to other developed countries like UK, the waiting time of this patient to get the surgery and things. But here these flights are on time, loss of luggage zero, excellent food, but complimentary drinks are there, but successful landing is 78%. So anybody in the audience, can they book this flight to get it? So this is the problem. Still we don't have the proper mechanism to ensure our quality and patient safety mechanism. So I don't like to spend more time explaining about the clinical governance, but in our health system still we don't have, and it's lacking of proper clinical governance. So then we know all this clinical government has these main 5 components. So these governance and quality improvement, clinical practice, performance, skill management and incident and complaint management, and patient rights and engagement. So then the last lecture is Dr. Ranjit Dayal mentioned about this comparing the care in the UK and in Sri Lanka. Sri Lankan setup after my postdoctoral training, after being there in the UK, my personal opinion that if we can improve in this area, then we have better health system than UK. So this is the area we need to address. So we have to have a clinical audit and national confidential inquiries, evidence-based medicine, clinical standards, manpower planning, and continuous professional development and lifelong learning. So if we can address these things, we should be able to address the universal coverage with all these available resources, and also with adding the cost-effective way of doing things. So when we plan, we have to plan for the effectiveness and the efficiency. So doing right things in right way. So in the world there are so many evidences available that with community-based interventions will work out, and then there are about publications. So we have to move from this community-based, the system should establish from community to tertiary care, and not the tertiary care to community. So this is the health proposed health village model. Our department at the moment working on it also with other partners, Northern Provincial Health Sector and the National Ministry of Health. So already we have this community with all these village development committees, mothers clubs, PHIs, and senior citizens committees, recreation centers, and health clubs in the school, and all these facilities. So the MOHS officers are there. Then the agriculture and food department is working. So this base general hospital and the divisional secretary is a key person in the area. So we have put up this primary care center in the Kontaville, and all the people living in that area, now we did the survey by using the medical students, and now we are developing a computer package also to insert all the information that people living in that area. So integrating with the public health midwives and the PHIs. So the area MOH and Department of Community Medicine, we go and screen all the people, then refer to the clinic. So the clinic, we provide all these primary care service. Then after the services, we try to refer to all the hospital tertiary care and then refer back. This is a model we are proposing, and also we are practicing, start to practice, particularly to teach our future medical students, and also then we are developing this rehabilitation center, and also developing these palliative care services. So in future, I'm quite sure in 5-year times, this area we can show this model healthy village setup that could be the good model to the world, and also this national thing as a model to achieve the universal health coverage. So this is my lecture, the final summary. So we need to develop that if we want to achieve this model, we have to have a good human resource development, so training of staff and recruiting new staffs. So things are happening. Then we are getting more and more cadres, and also we are getting the land facilities adjacent to the faculty to develop a polyclinic, so to show this model. Then also in the right, almost we are in the final stage of developing health information, that electronic database. So then once we develop, then we may be able to link up with the other electronic database. Already the pediatric department got the electronic database. So we will be able to link with the teaching hospital and referral and back referral mechanism. Then health promotion activities already we are doing, and students most of the time they involve. And community empowerment and mobilization, and also this working with partnership is happening with the district secretariat, MOH office, and all other stakeholders. So thank you very much for the organizing committee to share this, and also the concept what we are developing at the moment.